Hi everyone, I'm Sadie Zacharek. I'm a PhD candidate in brain and cognitive sciences, and tonight I'm going to propose a predictive model for mental health precision medicine. So to start, I'll give you a sense of the scope of the problem of mental health in our country. So mental health conditions are quite widespread. Presently, an estimated 1 in 5 Americans is living with a mental health condition. And in the course of their lifetime, it's even greater. An estimated 1 in 2 Americans will suffer from a mental health condition. So this problem is not only widespread, but incredibly costly. There's an estimated economic burden on the order of magnitude of hundreds of billions of dollars. Major depression alone comes with an estimated economic burden of $326 billion. So this problem is not only widespread and costly, but incredibly difficult to treat. And to illustrate why, I'll start by stepping back and giving an example of how we treat physical health conditions. For physical health conditions, we have a really solid biological understanding of the physical mechanisms that underlie the condition and enable us to perform effective treatment. So for instance, if you had a cardiac condition and you went to the doctor, there are a set of tests that they can run to establish biomarkers or biological markers of the disease, things like blood tests or EKGs to help us learn more about the disease, and also how we can effectively funnel these patients into treatment. And this can help us choose both between classes of treatment, so maybe a lifestyle change like reducing sodium intake or increasing exercise is indicated, or maybe choosing between different pharmaceutical drugs. And because we have this solid physical mapping, we're able to effectively channel patients into the best treatment for their individual case. However, that's something that's really lacking in mental health conditions. We don't have a great physical understanding. Part of this is how we diagnose mental health conditions. So the DSM, which is used to diagnose mental health conditions, primarily relies on diagnostic criteria of patient self-report. Things like excessive worry and anxiety disorders, or loss of joy or pleasure in normal activities in depressive disorders. We're beginning to find biological markers of these conditions in the brain with tools like MRI and EEG, but this work is ongoing, though we have found some robust biomarkers like hyperactivity of the amygdala in anxiety disorders or hyperactivity of Brodmann area 25 in depressive disorders. However, the link between these emerging biomarkers and individual treatments, either classes of treatments like psychotherapies, cognitive behavioral therapy, or talk therapy, or between different pharmaceuticals like different antidepressants, still remains poorly understood. So though we have these emerging biomarkers of the disease, we have no real way to leverage those into individual treatment recommendations. And so if we can't individually tailor treatment recommendations to a patient, what we're left with instead is this trial and error approach, whereby a certain treatment is tried, assessed for whether or not it has worked, and if not, we move on to another treatment. And as you might be able to imagine, this approach does not work well for the majority of patients. So to use depression as an example, about 2/3 of patients with depression do not benefit from the first antidepressant that they try. And even more strikingly, up to 1/3 of patients remain symptomatic following 4 successive treatments. And unfortunately, this process can take months or years for patients to find a treatment that works well for them. And as you can imagine, that ends up being quite discouraging. And it's quite common for patients after multiple failed treatment attempts to become so discouraged that they stop seeking treatment altogether. So the question is raised of how we can move beyond this trial and error approach of iterating through treatments that might work for a patient to starting with a treatment that's likely to work for a given patient in the first place. And so for that, I've envisioned a predictive model for precision mental health treatment, whereby we can leverage machine learning to provide the link between these biomarkers to funnel patients into effective treatment selections. And this model, of course, relies on 2 key premises. One, that the brain is even the right spot to be looking for biomarkers. And second, that machine learning is a technique that is well suited to this problem. And so to speak to proof of concept for those 2 premises, I'll discuss a few recent studies that I think provide pretty good evidence. So beginning with the first question of whether brain measures are the right sorts of data to be basing these types of decisions on, I'll look to a study that came out examining response to cognitive behavioral therapy, which is a common psychosocial therapy in social anxiety disorder. So trying to predict the effectiveness of CBT in individual patients was able to be ascertained at around 12% based on clinical data, specifically based on the initial clinical severity of the anxiety alone. When brain measures began to be added in, brain structure, function, and especially the combination of brain structure and function, this number increased. Considering brain structure and function together accounted for about 60% of the variance in response to CBT. So this constitutes a 5-fold increase from clinical measures alone. So this gives us some evidence there is something especially informative about the brain. And further, the second premise that we need to examine is whether or not machine learning is well suited toward this problem. A few studies have come out in recent years trying to leverage machine learning to predict in individual patients whether they will respond or not to a given treatment. And these studies span pharmaceutical and psychosocial treatments. You'll also notice that they span a range of disorders: post-traumatic stress disorder, anxiety, depression, schizophrenia. And on average, they find between 70 to 80% accuracy from an individual patient. Although it should be noted that though this represents, a marked increase from the per chance figures we were discussing before, these are by definition post-dictions rather than predictions. So these are looking at patients who, based on their baseline brain data, we're predicting how they've done, but we already know how they've done. So this is not a true prediction in the sense I'm talking about, which is not to say that these studies are not useful in any way. In fact, I think they'll serve as valuable training data for a predictive model. So to give an example for my own thesis research, there's an ongoing clinical trial for adult social anxiety disorder in which we're collecting pre-treatment clinical data as well as pre-treatment MRI and EEG neuroimaging data. Following this baseline visit, participants will undergo either 12 weeks of cognitive behavioral therapy, a psychosocial treatment, or they'll undergo 12 weeks of sertraline, a pharmaceutical anxiolytic. And after treatment, we will collect both the same clinical measures, again, to ascertain whether or not the treatment was successful, but crucially, we'll collect the same neuroimaging data so that we can ascertain how the brain has changed in response to treatment. And we are far from the only neuroscientists to investigate studies like this. There are many other studies investigating similar pre-post changes, and I think we're more poised as a field now than ever to combine all of these individual studies in a cumulative way. And there are two key reasons that is the case. So existing clinical neuroscientific data is especially well poised to be used as training data because it's being now openly shared and standardized. From the openly shared perspective, it's become a trend in the field in the last decade or so to openly deposit your data so that it can be used by other research scientists. So OpenNeuro is a common site where scientists can voluntarily deposit their data, and as of this morning, there are over 42,000 participants with their neuroimaging data shared on OpenNeuro. And also, some funding sources have begun to mandate the sharing of clinical data. So the National Institute of Mental Health, for instance, last year put out a proclamation that anyone receiving funding from them needed to begin sharing their clinical data. So we have more of this data that would be valuable for training available than ever. And also the data in the last decade or so as well has become increasingly standardized. So the same structure is being employed across these studies. And some studies are even harmonizing their data collection parameter down to the level of individual MRI parameters to standards such as those in the adolescent brain and cognitive development study. So it's easier to draw a near replication from these studies, and we're in, I think, a better place than ever to combine all of these into a cumulative science. Okay, so now hopefully I've convinced you that we have good training data available. So what about the testing data, the data we would need to acquire from individual patients? Luckily, I think that that data can be securely and readily obtained. So the two sort of neuroimaging modalities, MRI and EEG, that seem to be the most predictive in the literature for change are non-invasive and safe to collect. In fact, you might even argue that they are safer than some common medical tests. So MRI, for instance, doesn't collect or does not produce any ionizing radiation, unlike X-ray or CT scan, two common medical imaging modalities that we might use for a physical health condition. Additionally, it's quite quick to collect this type of data. The types of data that are most predictive can be acquired by neuroscientists in only a couple of hours. And of course, when we're thinking about interfacing a new technology with private health information, privacy is a tantamount concern. But luckily, the output, from these two modalities is not readily identifiable. So the electronic data from EEG has no identifying information. And even the high-resolution structural MR images are commonly defaced in processing. So this is an image of my own brain that I took. And as a routine processing step, my face was digitally kind of chopped off, so you wouldn't be able to tell if I hadn't told you that this image had come from myself. And so once we've collected this data securely, ideally, there would be no more risk to privacy than any other electronic health record. And so now to envision the output, I think ideally the output would be easy to understand and accessible to both clinician and patient. Ideally, it would have the ranked treatment options for a certain condition that are available with the likelihood in which they are to benefit an individual patient. And the key portion of this being accessible and easy to understand is so that the eventual treatment selection can come about through a conversation between a patient and their clinician, as patient involvement in care decisions has been shown to improve patient outcomes. And of course, with a ranked list like this, there is always the possibility that the output would indicate that there's not good reason to be confident that existing evidence-based treatments would work well for a patient. And so another idea I had for the output would be that all federally funded clinical trials in the country are required to be registered on clinicaltrials.gov, which is easily digitally accessible. So the output could also include information about clinical trials of novel treatments that participants may be eligible for if no evidence-based treatment seems suitable. So in summary, I think that a predictive model for mental health precision medicine could maximize the utility of existing neuroimaging data and provide it with real clinical value for the first time, could provide clinicians with objective evidence to guide treatment selection in a way that is so crucial for how we treat physical health conditions, but entirely lacking in how we treat mental health conditions, decrease treatment duration and the number of failed treatments that patients need to undergo before they find a successful treatment that works for them to hopefully encourage treatment-seeking behaviors. And along with that, if patients are needing less time to undergo treatment, then ideally this will ease the nationwide mental health professional shortage we have. And from a utilitarian perspective, this would reduce the economic burden of mental health, but most saliently, this would promote faster paths to individual recovery and more effective tools for patients. And I think from an economic, public health, and humanitarian perspective, this would represent one of the most meaningful advances in computing. So thanks for your attention. I'd be happy to take questions.
Thank you, Sadie. Questions for Sadie?
Thank you for the talk. Do you think existing methods for measuring brain activity like fMRI, that's enough? Or do you envision other technologies that are on the horizon or might be motivated by mental, like precision health, that we should be looking into to enable this to enable better precision?
Yeah, that's a great question. So I think there are currently some really exciting advances in MRI, EEG. There are also a lot of other methods like MEG, magnetoencephalography, or FNIRS, functional near-infrared spectroscopy, or magnetic resonance spectroscopy that hold a lot of value. And I think that the most predictive data will likely come from a combination of these. I think the more fine-grained, comprehensive picture we can form of the brain and the more detailed ways we can image it will end up being the most informative, because I really doubt that it's any one thing that one modality is measuring that's most informative. So fMRI, for instance, measures the blood oxygen level dependent response, which areas of the brain are metabolizing oxygen and thus we infer they're most active. But I think if we were to consider that in isolation and not consider the neurochemistry of the brain or electrical activity firing like we would measure with MRS or EEG, we would just have a limited view of the brain. Thank you.
Hi. I have two questions, but they're related. So the first is, a lot of the imaging studies that we have historically, and even now, they work on small samples per study. And so their small samples have the sample bias that we see in general, specifically in imaging. We see mostly male, mostly white, and almost exclusively wealthy brains being imaged.
Yep.
And this is particularly problematic in a mental health setting where we know that the same set of symptoms described in a white patient is major depressive disorder, and that maps to being schizophrenic in a black patient. You can say the same thing and look the same way, and it'll just be a different diagnosis. And so how are you going to not replicate and calcify these known inequities in the healthcare system, specifically in mental health, where we have a huge gap, with a predictive model, which maybe has the sheen of objectivity and would be harder to question than a clinician. So that's one question. The second is, what do you do when the reason you're depressed is because the world is depressing? I don't think that that's not always addressable, right? And again, conditioned on your status in society, that may be actually not addressable except through systemic changes.
Yeah, those are a great pair of questions. So to answer them in order, I think as with any sort of predictive model, your output is only as good as your training set. And so I think this will likely need to come about through targeted recruitment of these populations that have been historically, yes, as you correctly say, underrepresented in research, and to try to sidestep calcifying those differences and make this a model that works well for everyone. And I think a lot of the contributions to these openly shared data sets, or even where these large-scale data cohorts are taking place to be shared on sites like the National Institute of Mental Health Data Archive, are primarily occurring at institutions that primarily recruit undergrads who are white, educated, Western. So I think there would need to be a targeted effort to ensure that there is recruitment of representative subjects for the training data. And then to your second question, sorry, could you remind me briefly?
The world is dark.
Oh, yeah.
And it's and it's maybe darker for certain people.
Yes, okay. So I think that there is also a big question of when we should pathologize mental health struggles and when they are actually indicated. So as an anxiety researcher, this comes up a lot. Like if someone has maybe been raised in an environment where hypervigilance is actually adaptive to survival, how are we going to tell them that it's actually pathological? And they shouldn't be on high alert all the time. And so I think in the context of this predictive model, that's why I'm envisioning that the output for treatment is actually coming about through a discussion between the patient and their clinician. So this is not a unilateral, this machine is making the decision. Crucially, the patient should discuss this with their clinician who is conscious, has empathy, and has a good understanding of the subjective scenario. And maybe they decide something like a change to the situation would be more beneficial than a pharmaceutical intervention.
Another question.
Thank you so much for your talk. It was really insightful. I guess I kind of also have two questions. My first one kind of comes from the idea you said, just like talking to your clinician, but you also say objective evidence. Like a lot of mental health treatment is different from physical treatment because it's a very emotional process. It requires I guess the idea is that not everything is purely just physical markers, and treatment a lot of time has a really humane aspect of you talking to a therapist, you talking to your psychologist, and that sometimes is plays a really big role. And you talk about CBT in that sense. How do you think using ML would actually play a role in that sense and actually make a change that does help, for example, ease the mental health professional shortage when you still need that humane aspect? And I guess my second question is a lot shorter. Is just, what do you think is preventing us from having this right now? Because it seems like we have all the technology and the data and the science. So I don't know, maybe there's some barrier there. Thank you.
Yeah. So to begin with your first question, I think that using objective evidence would just help to, guide the treatment selection, but it still ultimately would be a choice. So it's allowing clinicians to make a more informed choice. And as you point out, there still is the human aspect to delivering, say, psychotherapy. And I think that, this is different depending on the treatment modality. So if we're talking about a psychiatrist who's going to be prescribing a certain pharmaceutical and they're choosing between two closely related classes of antidepressants, then the objective treatment is more of an easier decision. Whereas if we have a psychotherapist who's going to be administering a psychosocial treatment, then we need to take into consideration which therapies the psychiatrist or psychologist, is trained in providing, and also maybe considerations about what the patient would like. Maybe the patient doesn't want to take a psychoactive drug and they would be more inclined to follow a psychosocial route. So I think that something like this would provide objective evidence to guide treatment selection. I think ultimately it could never be something that was fully automated. And then to your second question of what's preventing this now, I think that the pieces are largely in place, but it becomes a matter of both implementation and acceptability to the client in this case being clinicians. So we would need to implement trials where patients at clinics, preferably large volume clinics, so we can get representative samples, are trying out an algorithm like this and seeing if that improves their odds ratios of actually being treated more effectively for their mental health conditions. Also, there needs to be, I think, studies of how clinicians actually feel about implementing this in their practice. This is quite a departure from how mental health care is typically thought about and how patients are siloed into the appropriate treatment for them. So I think piloting would be the only way to actually, ensure that this is actually a real-world feasible movement.
Great.
Yeah, thanks for the interesting presentation. So, what you think about the FDA's policy around the medical device as a software? So, when you Google artificial intelligence and machine learning enabled medical device, FDA only shortlisted 700 to 800 softwares to be considered, and only that softwares are considered as medical device, and only that softwares can be used in the medical purpose. So I think it's just limiting some chance for some grad students and some researchers, because it is hard to develop that kind of some medical device without some great fund from the industry and some big money. So what you think about the FDA's policy, and do you have some solid plan to get their how can I say, a policy endorsement?
Yeah, so it's an interesting question. So I think if we were to think of this as a tool that we would want FDA approval for the software, I think I would envision this more as a diagnostic tool. Ideally, this would be something that public health professionals, academics, neuroscientists, researchers, and clinicians would all want to be working toward together. I'm not as familiar with the guidelines around FDA software, but ideally, I would hope that something like this would be deemed as effective and productive.
So thank you very much. That was really fascinating. I have a question that is about the environmental causes of mental health difficulties and kind of structural causes that's less about pathologizing than about measurability. So there's this sort of anxiety that when something is measurable, we tend to over-focus on it, and when things are hard to measure, they are neglected. So I'm a philosopher. Effective altruism is one case where work on social justice is neglected by effective altruists because it's very hard to measure the efficacy of political action, whereas malaria nets, you have a bunch of data. And so I wonder if you've thought at all about the question of whether there's an issue like that in relation to your intervention, that we can study the brain, we can do all these studies, we can get all this data, whereas the social and environmental conditions that might be structurally causes of mental health problems are much more messy and amorphous and multifactorial, and you can't just get someone into a room and put a thing on their head to measure them. And if there's a risk of sort of over-focusing on the things that we can study in this way.
Yeah, that's a really interesting question. And as a human subjects researcher, we always think about the fact that humans are noisy, and you can never, study a human ethically in a complete vacuum. And you're right that if we have these objective measures, we don't want to lose the humanity in the patient. And there, I think, is a reason that mental health conditions have been treated so qualitatively rather than quantitatively in the past. There is some, essential human component of suffering from a mental health condition. And I think that there are some, to think about some of the examples you offered, there are some scales and clinical measures that are able to ascertain things like neighborhood disadvantage, adverse childhood experiences that I think could provide more context, and some ML models that consider both these biomarkers in addition to these more sort of qualitative experiences, which I suppose by measuring them on a standardized scale, we are still quantifying them. But I think there is still room to consider both, and there is at times a modest increase when we consider these kind of contextual factors in addition to the biological.
And the final question Hi. Hello. Thank you very much. That's really very interesting, and I think it's exemplary of a very familiar, common, and important way of doing research, where you have a prior condition, and then you have some possible outcome conditions, and you're offering us a technology for analyzing the relationship on the basis of the correlation between the prior and the subsequent. So I'm a little worried, or maybe you just didn't have time, because I don't quite understand how this, or your model, shows us the mechanism of how the signs in the brain become the cause or simply the symptom of the mental disorder. So I'm not clear about that.
Yeah, I'd be happy to clarify. So brain biomarkers, I think, primarily can fall into two classes. We can think of them as something that is involved in the causal mechanism of how these symptoms arrive, or as kind of a scar, or how these symptoms are leaving an imprint on the brain. And I think we can come to disentangle these causes versus consequences when we have longitudinal studies, so studies that look at patients in a pre-symptomatic condition, or maybe in a post-symptomatic condition when they have had this condition and then successfully been treated and are no longer symptomatic. So in a case where it is a consequence of a condition, we might expect in the post-treatment that these, whatever biomarkers we have, say heightened amygdala activity from anxiety, it's a pretty robust one. If a treatment is then able to make it so that a person no longer has that hyperactivation of the amygdala following successful treatment, then we can infer that that was something that was a consequence of the anxiety. Whereas if something is a cause, then we would expect that to be present in preclinical samples. So we would expect that it would be there in the brain before someone reaches a threshold of diagnosis. And I think there are a lot of ways in which we can try to ascertain those, but longitudinal studies seem to be the best focus so far.
Yeah.